Okay, so it's exactly 4:30 sharp, so we have to start. Welcome to this sponsor session by Medtronic dedicated to drug-coating balloons. It's a very practical, this is the objective, how do I confidentially expand my drug-coating balloon practice? My name is Flavio Ribicchini, I work at the University of Verona, and I'm the anchor person of this session. The spokesperson is Dr. Hu, and we have a panel of speakers, very distinguished, you know them very well. Dr. Bruno Scheller, Dr. Matthias Goldberg, Dr. Cambis Massachetti, Dr. David Hildreth-Smith, and that's all. So very briefly, the objectives of this meeting are to reflect on when to use drug-coating balloons and stents, when to use drug-coating balloons or stents, to analyze clinical data and the use of drug-coating balloons in bifurcations, which is a very long expected indication, and to evaluate which dissection can be left or should be stented. So very practical, and with no further delay, I will call Bruno to start with the first presentation. Thank you.
Dear Flavio, ladies and gentlemen, I'm very glad to be here and to be allowed to give you some of my ideas about differentiation between DCB and drug-eluting stents. This has been shown multiple times from this huge stent meta-analysis showing that we see beyond the first year no difference anymore in different technologies, and we have this device-associated event rate of 2 to 3% per year, and as it looks now, this never stops, and therefore it makes sense to reduce the total burden of stents at least. This is also data from this meta-analysis with about 20,000 patients. And what you can see here is that drug-eluting stents do the very best in non-complex coronary artery disease. And I think if we talk about comparisons between DCB and drug-eluting stents, it makes no sense to try to challenge DES with DCB treatment. However, if we look more in detail, this is a very busy slide, it is clear that the more stents you implant, the longer stents you implant, and the smaller the stents are, the higher the event rate goes. And that's then the more complex scenario where it makes sense to use drug-coated balloons. We conducted the Basket-Small 2 trial years ago, 758 patients randomized either to DCB-only treatment or to drug-eluting stent treatment of vessels smaller than 3 millimeter in diameter. And here you can see the MACE rate up to 3 years, and as you can see, there was no difference at all in this patient population. However, we have to recognize that in this trial, it was allowed to treat also larger arteries with typically stenting, and we had a lot of statistical noise here due to the larger vessels, so that we could not see a separation of the curves, which we hope for beyond the first year. However, we can see this now in a larger analysis, a patient-level meta-analysis, the Andromeda study recently published in the European Heart Journal, including the patients of Basket-Small 2, but also from Bello and Piccoletto 2, and in an additional analysis from Restore SVD China. And here you can see for MACE that the curve is flattening for the DCB group, and we have this higher event rate in the drug-eluting stent group, which is significant at 3 years. If we look at target lesion failure, there's numerically at least also an advantage for the drug-coated balloon. If we go back to the stent data we have, drug-eluting stent data we have, then we can see that vice versa against non-complex coronary artery disease, diabetic patients do worse with drug-eluting stents. And here you can see from the Basket-Small 2 trial the subgroup analysis of diabetics versus non-diabetics. And here in red you can see the diabetic patients that underwent drug-eluting stent treatment, and they have by far the highest event rate compared to all 3 other subgroups, namely non-diabetic patients with stent or DCB, and diabetic patients treated with drug-coated balloons. So here we have a clear hint that, for example, in this patient population, DCB may make sense in smaller arteries. And in this recently published meta-analysis in diabetic patients from all this randomized data we have, DCB versus drug-eluting stent. Those authors report survival benefit at 2 years when using DCB in diabetic patients instead of drug-eluting stents. For us, the decision between using a stent or a drug-coated balloon is based on the result of the lesion preparation, which is mandatory. So at the end of the day, in most of the cases, we have a hybrid or blended approach where the one patient has one lesion treated with a drug-eluting stent and maybe several additional lesions treated with drug-coated balloons. And this has been investigated by Professor Shin and her co-workers from Korea. They looked at patients with multi-vessel disease, and the strategy of a 100% drug-eluting stent treatment or the application of the DCB-only algorithm, resulting in 2/3 of the lesions treated with DCB only and 1/3 of the lesions treated with drug-eluting stent. And this approach was associated with a significantly lower event rate at 2 years compared to the 100% stent approach. I will show you a case how to apply DCB treatment in complex disease. This is a 67-year-old male, diabetes mellitus, hypertension, hyperlipidemia, smoker, and adipositas. In addition, he had criteria for high bleeding risk, intermittent atrial fibrillation, and he has a known coronary multivessel disease with end-STEMI in 2019 and treatment of the proximal and mid-RCR with drug-eluting stents. And he came back to us in April 22 this year and underwent a complex PCI in a highly calcified LAD, which we treated with IVL and DCB with Prevail. And then 3 weeks later, he came for a planned stage procedure for the treatment of his circumflex artery. The reasons for having DCB approach in this patient was his relatively young age. We had lots of calcification in his arteries with the risk for stent under-expansion, and he had criteria for high bleeding risk, which is also a reason to try to avoid stenting. So this was his circumflex artery. You can see here this high-grade stenosis and also disease in the mid part. And this is the high-definition IVUS we did in this patient. And you can see lots of calcification in this circumflex artery. We start again. And you can see here that it's almost occluded from the IVUS device and lots of circular calcification. And this was the overview of this IVUS. So what we do? We started with non-compliant balloons that were able to crack the calcium. These are the two most diseased parts here and there, which you can see here in the IVUS again. And then we did IVL in the distal part, cutting balloon in the mid part, and this was then the angiographic result after lesion preparation. This is again the high definition IVUS, and you can see there's still calcification, but we have cracks in the calcium, and the lumen also get significantly larger in those areas treated with IVL and cutting balloon. And therefore, we had the option now to avoid stenting, and we used the 3.020 Prevail in the mid part and 2.520 in the distal part. And this is the final result here, no stent in this area. And if you look here at the IVUS images, calcification is still there, but the lumen has, in addition, more improved after the DCB treatment. And this is the virtual FFR we did afterwards with the CASWork system. And here you can see that the FFR volumes, even in the distal circ, are very, very good with an FFR of 0.92. which supports this concept of avoiding stenting in these highly calcified lesions. So the DCB-only strategy does not intend to replace stents, but to reduce the number and length of stents. We have to focus on lesion preparation, and we know that careful lesion preparation improves the outcomes of stents and DCB. The device selection for lesion preparation depends on the lesion complexity, and we have more and more patients with severe calcification, as in this case, and then you can do all the new tools we have to control the calcium. The decision is on a per lesion basis and not a primary strategy. And we have more and more data now and more experience that show us that intravascular imaging and physiology are very helpful also in DCB-only treatment. And in the future, it makes no sense to compare one device with the other, in my opinion, but we should look at strategy trials aiming to reduce permanent implants, and I think that's very promising. Thank you very much.
Thank you very much, Bruno. So I remind you that you can make questions through your iPad. We have a spokesperson. Spokesperson means that we'll speak on your behalf, so he will gather your questions. I think that you can also go to the microphone. I hope I see microphones, but please do not stay there. It's a little bit dark. We don't want you to sleep. So make questions. And of course, Bruno, you are provocative, because if there is a conviction is that a calcified lesion needs a stent, not only stent, it needs a stent with high radial force. And you are showing that this is not the case. Could you explain us why you decided not to put a stent and what you expect that this combined treatment of dedicated devices for calcium and local drug delivery might be better than the stents itself?
So, as I said before, you have, with this high amount of calcification, a high risk for incomplete stent expansion. That's for sure, and this increases the risk for restenosis, for stent thrombosis, of course. On the other hand, we know that calcium is a transfer barrier for drugs, so it makes no sense to use DCB in circular calcification, for example. So, but if you crack it, if you create channels for the drug to get into the deeper tissue, as it was the case here in this patient, then you can expect similar benefits from DCB in terms of late lumen enlargement, as we've seen it have seen it in non-calcified lesions.
Dave, you have always been a rebel guy, so I guess that you like what is not conventional. What do you think about this?
Well, I do like it. In fact, I love it.
Yeah.
So I think in all the situations where we have difficult anatomy, the worse it is, the more it's actually suited to not putting in a stent, because it's only in the last few years, and I think as Bruno said, that Mahadevan paper really resonated so strongly with everyone, because we went through all that phase of thinking, oh, that was only true of the old-fashioned stents, and these new stents, we don't get problems with them. But actually, we knew in our hearts that we did, because they'd come back after 10 years suddenly with a granite-like occlusion of the mid-right coronary artery. And this was happening, and the paper showed, 2% year on year on year on year. So actually, suddenly, at least for me, I felt, maybe we're not doing the right thing. Yes, we can get a beautiful result now, but then it's ugly later. Maybe the right approach is to have an ugly result now, which is beautiful later. And that's what you get with DCB.
Okay. Kambis, you are an expert on complex interventions. Do you share this thought? Or do you agree? Do you think we are exaggerating that stents are still very good for this kind of lesions?
Well, when we see the image and intravascular imaging, I still believe that in the big arteries, drug-eluting stent is doing quite well. What is well? DCB. So the problem comes up when you have a not perfect plaque modification, even if you've done everything. So that reminds me of eccentric calcification, calcified nodules. Here, nowadays, I'm quite defensive with drug-eluting stents because I see the instant restenosis quite high, as well as segments where we have high moving forces, causes stent fracture potentially. You know that all, osteocirc. And so there I'm getting more and more defensive over years with my DES strategy. If I have a perfect plaque modification and a large artery, still drug-eluting stents definitely works.
Any comments from your side? I mean, we don't see, we have the light here, so we don't see you. Probably you are all sleeping already, no? You have a question?
Yeah.
Great.
So we have a question, Bruno, from the floor, because you showed a very nice case of the IVL and then the DCB, but then sometimes for calcified lesions, you may not get a residual stenosis of 30% or less. So there was a question that if you have slightly more than 30% recoil on angiogram or IVUS, are you still happy to proceed with the DCB?
So this 30% is some artificial, to be honest, because when we did this recommendation in the DCB consensus group, some people said, okay, 50% is enough, but we said, okay, that's not good. There's per definition restenosis, and 10 to 20% is hard to achieve. So let's take 30%. So that's why we talk about 30%. But this is eyeballing, and this 30% eyeballing is typically 40% by QCA. And there are data showing that, really showing that beyond 40% QCA, the event rate goes up. And then you have some plateau, and from 25 to 20% residual stenosis downwards, then you have an improved result. So the goal is to reach 20% or less, but you can accept 40% by QCA.
Bruno, the rate of TLR is going up no matter which device you put in, right? Because the plaque preparation was probably, I mean, not perfect, right? Because you cannot do better in some cases, right?
Yeah, I fully agree. I think the same applies for the stents. Yeah.
Okay, now we move to the next presentation. Thank you, Bruno. Thank you very much. Matthias will address something that has been hypothesized and discussed for years, which is the use of DCB in bifurcations.
So thank you. It's a pleasure to present this. This is actually two different parts. First, I'm just going to show you a hybrid DS DCB case, and then I'm going to present the data from the SCAR DCB bifurcation registry. Here are my conflicts of interest. So let's start with the case, shall we? So this is a female. She was born in 1952. She only has hypertension as before. And she arrives to our CCU with a small non-STEMI, and this is 2 months ago. RCA just shows mild non-obstructive disease. Same thing for left circumflex, just mild non-obstructive disease, but we can actually see that there's a little bit of a lesion LED diagonal branch. If we go areocranial projection, we see that LED has a moderate lesion. The diagonal branch has quite a severe lesion. That's probably the culprit lesion in this case. We can debate about, the mediana. There's actually not much plaque in the proximal part, but it always stretches into the proximal portion anyway. But so how did we treat this? So the first thing we did was just treat the side branch with predilatation, 2.0 balloon, and then we did imaging. And I think this is really good to do imaging, and this is really part of our standard practice today. So the landing zone in the diagonal branch is 225. So it's a 225 vessel. We know that the distal portion of the LAD, the mid portion of the LAD is about 325, and we found a very healthy segment, so quite focal disease. The LAD proximal landing zone had a little bit more disease, but I think a fairly low plaque burden as well, and it was 3.1 millimeters. There was a little bit of calcification on the opposite side of the diagonal branch, but not too much. And here's what we typically do. We applied a DCB at 225 in the diagonal branch, so we used 1-to-1 vessel sizing, got a nice expansion of that. And then we followed by just simply stenting over past the diagonal branch in the LED with a 3.0 by 34 millimeter stent at high pressures, which means you obviously gain a little bit more diameter. So we saw immediately we had stent under expansion, which we know is not good. So we post-dilated with 3.0 NC balloon at high pressures, and we got rid of that. So looking at IVUS, looks good in proximal, and in the mid part, good expansion, no dissections. So there's a little bit of a mild to moderate residual stenosis. We can debate on the percentage of that. At the same time, it's a 225 vessel, and I typically didn't want to go for a 2-stent technique. And there's also no visible dissection, and there's also good T3 flow. So I think it's reasonable in a case like this to leave this. So this was the final result. And this is a 15-minute PCI as well, so making bifurcation easy. So this is actually interesting because we do this a lot. We don't have a lot of data supports use, but if we look at the SCAR registry, we do have a bifurcation module where we track this, and we find that using the hybrid DCB approach is actually quite frequently used in bifurcation lesions as part of the provisional strategy. So the question is really, is this a good bifurcation strategy? There's not too much data on this. We have the DCB bifurcation study, which we can debate about later, but there's just smaller case series to tell us whether this is good or not to put DCB in diagonal advantage or not. And we do have some data, and this data was presented earlier today in conjunction with the PREVAIL balloon and looking to elucidate the data in the SCAR registry with the PREVAIL versus the other DCBs. So the PREVAIL is introduced in Sweden in 2021 and is now the most commonly used DCB in Sweden. And we used our SCAR registry, which is a national quality registry, where all patients in Sweden undergoing a cath or a PCI, they get put into this register. So we track all patients with no patients lost to follow-up. And we actually looked at all DCBs and then looked at only the bifurcation, which is the study population. And we had slightly less than 1,500 procedures, but more than 1,600 devices in this. We compared PREVAIL with the other DCBs. So overall, in terms of patient characteristics, this is very typical of our practice today in Sweden. More than 60% were ACS patients, and with a fairly high proportion of multivessel disease. In terms of device characteristics between the DCB versus other DCB group, PREVAIL versus the other DCB group, they were overall very similar. Interestingly, ISR is only been a minority of what we're using it. We're mainly using it for de novo lesions today. A very high procedure success rate in both groups. Use of intravascular imaging was 23%. It's actually increasing in Sweden a lot now. And then we did another thing is that we looked at DCB only versus a hybrid approach. In other words, DCB plus stent. So here's where the hybrid approach comes in. And we looked at PREVAIL versus other DCBs in this context. And the groups are somewhat different because the indications are somewhat different. So in the DCB only group, we tend to use it more in ISR, and it seems to be more frequently used in the left circumflex, whereas the hybrid approach seems to be more used in LAD and less frequently in ISR. And here are the bifurcation characteristics. Of note, I would say 2/3 of the patients had a little bit longer stenosis length in the side branch. We typically have 5 millimeters as our cutoff point. And the degree of calcification was moderate to severe in a little bit more than 1/3 of the cases. So here's the results. So overall, we see similar results between PREVAIL and other DCBs in terms of target lesion revascularization of these 1,500 patients. Interestingly, like I said, the groups DCB only and DCB plus DS groups, the hybrid groups, are inherently different. And we do see a difference here with a higher rate of target lesion revascularization in the DCB only group, which is probably expected because those are more sick patients and they have more ISR. In terms of myocardial infarctions, numerically looks very good for the PREVAIL, but this is not statistically powered for anything. This is observational data, and it's only 12-month data, so it's really statistically no difference between the two groups. Same thing with all-cause mortality, so no difference between the two groups. DCB only and DCB plus that does very well as well. In terms of definite thrombosis rates, if you note these, the fact that it's actually very few events in this because there's not that many patients. So it's not very common to have a definite thrombosis when you put in a DCB. So my conclusions are from this is actually the largest analysis today comparing different DCBs for bifurcations. And one important note is the hybrid approach is actually associated with an overall quite favorable one-year outcome in bifurcation lesions with a TLR of less than 2%. And of course, the PREVAIL DCB had comparable outcomes with other DCBs at this one-year follow-up in bifurcation solidly, but this is a real-world population because it's from a registry. And the results of this was consistent when we looked at it alone or when a hybrid approach was used. Thank you very much.
Thank you very much, Matthias, for a very nice talk on bifurcation. We just want to open for any discussion from our panelists and the floor.
Well, I mean, what is interesting now is that David and I should be in another room for an investigator meeting of and Bruno, I think, as well, right, from the EuroPCR Club. And they are going a step further, and it will be a comparison of true bifurcational lesions with DCB versus drug-eluting stent. So even the main branch will be treated by DCB. So we do that already in our daily practice, and plaque preparation is again a key role, and especially to be able to limit the dissections. So. That might be also something that we have to, let's say, give us an advice that in some scenarios it's just a scoring or cutting balloon makes a little bit more local plaque preparation compared to plain angioplasty, and that helps a lot to control the dissection plan and makes the primary outcome often very, very good, and I suppose as well the long-term outcome.
Yeah, I'd agree with that. And I think we've got used to being quite lazy operators generally since the stent came along, because once we realized that we stented everything, we just sort of pre-dilated a bit and then put a stent in. And when we do drug-coated balloon therapy, we know that the drug-coated balloon is simply to paint the walls with the drug. It's for no other purpose. So you can't require anything more of it than that. Whereas we've used the stent to sort of do a lot of the heavy lifting. And so that means that we have to have much more focus and go slower on pre-dilatation with non-compliant balloon, scoring balloon, cutting balloon, repeat cutting balloon, and gradually assess the results as we go. It's a stepwise analysis and eventually apply the drug to the artery. And I firmly believe that that is the way that interventional cardiology is going to go over the next 10 years.
I mean, Flavio, there were so many bifurcation sessions in the past, right? I learned so much here from PCR. Now it's my 14th year in a row that I'm coming here. And I remember when I come the first time, I didn't have a big idea about all the bifurcation strategies, and they were developed, right, up to culotte and everything, and provisional, and tap technique, and so on, and DK crush. So, but nowadays we're going back and we just treat the side branch very often just with a DCB and it works, right? So do we still need the bifurcation techniques then?
Well, it's what Dave said. What we need is good vessel preparation, and then the concept, which is very important, is that drug-coating balloon is not a balloon actually, it's a drug carrier. So you do a good job, you leave the drug, and then you hope this will be enough, but this is what we are trying to understand. And in this specific setting, I want to ask Matthias very briefly, if you have data on the subgroup of patients, the most important, which is the ostial circ, provisional stenting to the LED and ostial circ with DCB in your large registry.
We don't, or actually we do, but it's not, it's not enough patients to actually draw any conclusions. So I agree with you. I mean, that's the ostial circ is just one of those areas where we actually use the hybrid approach a lot because we want to avoid stenting due to the movement of the proximal circ, and it's very prone to ISR. But the data set is not large enough to draw any conclusions from as of yet.
Bruno, before we move, we want one word from you as a father of the technology regarding the perspectives of using DCB in bifurcations. 1 minute.
So one of the discussions we had with the EBC, Dave can comment also on this, was the sequence how to treat, because one of the very clear statements from EBC was you have first to stent the main branch, and then you are allowed to cross the stent and go to the side branch. And this was exactly the opposite what we as DCB guys said. We said, okay, prep both, give your truck to the side branch, then forget the side branch, and then you can do whatever you want with the main branch. And so it came up of this new study design of the EBC DCB trial.
Yeah. Can we make a short advertisement? I mean, we have just published in the European Heart Journal a consensus document on the treatment of bifurcations with DCB, so this will be of your interest. And of course, Bruno is one of the authors. Thank you, Matthias. Come back among us. And Dave, it's your time. It's a very interesting topic. It's something we are all very concerned about, is how to deal with dissections after the lesion preparation.
Yeah. Okay, so angioplasty is dissection, so don't be afraid to see dissection. In fact, I saw a case Colombo did not long ago with a DCB where he said at the end of it, and I won't do the accent because it would be embarrassing, he said at the end of it, I'd like to see a little bit more dissection, to be honest. You know, so it's a question of completely rethinking our angioplasty approaches. Okay, so this is a completely evidence-free zone, which means that I'm absolutely at my most comfortable. So I'm just going to show you, I think, 6 cases, and we're going to discuss them. I think we might as well just discuss them as we go. So I've made my own rules up, which are a version of the rules that Bruno has made, which is, first, you do not need to stent if you have TIMI 3 flow, lesion expansion, so we'll leave out that 30%, 20%, 50% thing. You need lesion expansion. And dissection, but without propagation of that dissection or persistence of dye within the dissection. So those are my personal rules. I've no idea if they're right, but I try to stick to them. Okay, so 6 cases. Here's the first one. So this is a relatively straightforward one to start with, a bit of a slightly calcified, angulated area. And I think you've got, with all of these, I'm just going to show the start at the end. So you can take it as read that these have largely been treated by progressive and stepwise application of maybe a compliant balloon, maybe a non-compliant balloon, then almost always some form of cutting or scoring balloon repeatedly at low to medium pressure, like 8 to 12, but very specifically 1 to 1. So we usually don't do that because we don't want to see a dissection that's too big and we're going to put a stent in. This is the opposite way of thinking. It needs to be 1 to 1, and you need to use the scoring or cutting element to create those dissection planes in a controlled manner. So this was treated along that line, and the end result was this. So I hope you can see here that we have a bit of dissection, linear dissection in the LAD here. It's a tiny bit hazy, but we have TIMI 3 flow. We don't have any dissection propagation. We've had reasonable lesion yield. So are we all happy to leave that one alone? I'm leading the witness slightly here, but as you're feeling a little sleepy, I'll just tell you, we left it alone. It's nice. It's a good result. We're very happy with that one. Okay, second case, slightly more contentious perhaps. Okay, so this is a lady with a subtotal occlusion of the right coronary artery in an ACS type presentation. So predilatation, 1 to 1. We think it's pretty nice. Actually, we had slightly the wrong size and length of drug-coated balloon on the shelf, which is, you know, something that you want to avoid. So that's a tiny bit generous. And after that, it looks like this. Mm-hmm. So, comments from the panel? Anybody want to say it's okay to leave alone or it's not okay to leave alone? So, panel or the audience?
Well, the dissection creates a residual stenosis which is more than 40%. So according to what we have been saying, it's not an optimal. I would try again, maybe with a cutting balloon to improve this angiographic result. Not worried about the dissection, worried about the residual stenosis.
Okay, yeah, the good comments, I like them. We sort of felt that this lady was staying in hospital anyway, and we were going to treat her left-sided vessels about 3 days later, and we thought reasonably confident that the dissection was retrograde propagating, and although it does look a little bit compressive at this stage, well, we left it alone, basically, to cut a long story short. Rightly or wrongly, it broke our rules, my rules, but we left it alone, and 4 days later, it looked like this.
Wow.
Well, so it's improving. It's improving, so, you know, maybe that's 95 times out of 100, maybe it's 99 times out of 100. I don't really know, but certainly we're all learning at this stage. So, you know, this one turned out to be safe to leave, despite the dye persistence. Okay, third case. It's a lady with very nasty diabetes. She's got some left main disease, which is going to be treated in a bit, but her presentation was with ACS related to this critical calcific right coronary lesion. You see, she's got some stents in the LAD already. And one thing that we haven't mentioned so far is one of the great advantages of DCB is to get you away from persistent antiplatelet treatment. You know, you all get asked 10 times a week, oh, this patient's going to have her colon taken out. We want to stop the aspirin and clopidogrel, or we did stop it 2 weeks ago and now she's got ST-segment elevation. This gets you away from all of that. You can say, yeah, that's fine, stop it for a week perioperatively, it's no problem. Okay, so I digress, but back to the case. So nasty looking lesion. In fact, we needed a guideliner and a tornus. Still useful, tornus 2.6 French, get through these calcific lesions to allow us access to the vessel. And then once we'd done all our treatments, it took quite a while, a lot of cutting, scoring, slowly. Using the cutting balloon, it's not just one inflation to high pressures, it's a one-to-one, not too high pressures, but repeated cuts. Try and rotate the device if you believe that works by moving it forward and rotating slightly and bring back. It will always be in a slightly different plane. Anyway, this was the final angiographic result. So can we leave that, or should we stent it? Panel.
Never you take another incidence. I mean, you decide on only one. Yeah?
Sorry, say again?
Do you decide always on only one incidence?
Oh, no. I was just trying to abbreviate the presentation because I wanted to get 6 in. And I didn't want to give you too much information.
Why don't we raise your hands if you agree in leaving this dissection? Hey, it's getting difficult to convince them, huh?
There's a couple. No, actually, that's a good way of doing it. I'll do that next time. Yeah, no, that's good. I mean, personally, partly because she has also left main disease and she has some stents already in the LAD, I wasn't that comfortable leaving it. It does break the rules. There is contrast persistence. So actually, we did put a stent in this one. Yeah. Oh. I don't like to be too predictable.
Okay.
Okay, next. This one, actually, Dr. Abu Erin, who's in the audience, did this one very nicely. So long segment of calcific, bit tortuous disease, typical scenario, ACS presentation, needs fixing, a fair amount of work done. This is the end result. I hope you can see that. I mean, it sort of degrades ever so slightly, but I mean, there's quite a lot of linear dissection there with wires cutting into eccentric areas of dissection. Who would like to put a stent or 2 stents in that? Show of hands.
Dave, is this the follow-up from the first case?
I mean, yeah, it's similar, isn't it? It's just a little bit more extensive.
Okay.
Oh, well, now, raise your hands. Who would leave this? I mean, definitely I would. So,
Yeah?
because
That's good.
Yeah.
That's good. So people are getting much happier to leave the dissections than they would have been even 2 years ago. I mean, myself included. You know, so we left this alone, and this has been good. Next one is actually only 45-year-old man with some other medical problems who's got a quite ugly-looking right coronary artery, predilatation, some dissections apparent, drug-coated balloon. This is the result. Okay, so Okay, who wants to? I mean, I don't want to lead. No, I can't say anything. I can't say anything without leading the witnesses. Panel.
I would put a stent.
Stent. Yeah, it's not wrong. It's not wrong to put a stent. I mean, stent isn't suddenly the enemy. Stents are brilliant when you need them. And that's why we're in such a grey era, because in contrast to the POBA era, where people didn't have any option other than bypass grafts, we get, if it's ugly and we don't like it, that's fine. Put a stent in. They're brilliant.
Yeah.
Bruno, what did you think? Bruno, for this one?
I wouldn't leave it like this. But I would first try to do some modification of the dissection you see. And in this case, I would use throwing balloons.
Okay. Yeah. So what we did actually, I mean, this one breaks the rules as well. This has dye persistence in the intima there, and we put a stent in. Mm-hmm. Yeah.
You are disappointing me.
I know. I'm so sorry. I'm so sorry. However, this one will not disappoint you.
Okay.
So this is Chalky Hastings' man. This man is a sort of classic Brighton case. 70-something, bad lungs, very bad kidneys, surgeons utterly uninterested, lots of angina. His circumflex is occluded, his right had some horrible stuff which has been dealt with, and now he's got this LAD. So, we did a lot of stuff. It took about 90 minutes, and this is how it looked at the end.
Also no rotor.
Did you rota, or was only balloon based?
Actually, it was shockwave, and it was cutting, and it wasn't rotor.
Okay.
Mm-hmm. I mean, here, probably better to leave it like it is.
Yes.
The stents, I'm not sure. I mean, imaging would be perfect, right, Dave?
Yes.
But I would rather leave it.
Yes. Who wants to put stents in this?
I don't want to.
Some
There
people.
are some people. Okay, good, yeah.
I'll tell you what I thought, to abbreviate the conversation. I thought I was a bit scared to leave it.
Okay.
But I knew that most of what we'd done hadn't really worked. So this was concentric calcification, extremely resistant to our entreaties, over 2,000 Hounsfield units. Everything that we were doing was actually only expanding the dissection element and not getting any lesion yield. So yes, the only technology we hadn't used was rotor, but by the time we realized that might have been useful, it was too late. So we had to leave it, really. I mean, putting stents in this, as Bruno correctly and nicely showed, this kind of chronic, horrible calcific disease does actually very badly with stents. So we've left it alone. We kept him in overnight because I was a bit anxious, I have to say. And he's done very well, actually. He's been angina-free, so, thankfully, again, N=1 anecdote, but he's done all right despite this very unpleasant appearance. So, finally, just back to my rules. I think they're broadly consistent with what Bruno would say. You don't need stent if you have TIMI3 flow, lesion expansion, and dissection, but without propagation or dye persistence. Thank you.
Thanks, David, for sharing your spectacular cases. I think there's some question from the floor, because I think some of the cases looks like type C dissection with persistence of dye, and of course you always worry about acute closure overnight. And would you consider using 2B3As to keep the artery open?
I'm not sure that will help in this setting. I mean, in my experience so far, and it's been maybe about 3 years that I've done this, I've only had one case of acute closure, which is obviously the thing people are really worried about when you start this. You think, how can I leave it so ugly? Surely some of these are going to close. But actually, I've only had one close acutely, and that was my fault because I left a dissection that had propagated further down the vessel. So I've been amazed at the resilience of the human body to resist all our attempts to defeat it.
Yeah. Probably one thing which I personally would add to the free rules is persistent SD changes or elevations, right? So no, well, because that you can treat. Sometimes you're curious, right? You have a long RCA, for example, you put DCB there, and then you have persistent SD elevation. So because of all the mediators, so that you have to fix with a stent, I think. But otherwise, those is also, by the way, like a criteria of trials, and it's exactly what you said. I left that alone based on trials where I included patient. I wasn't confident to do that without a trial. And then I learned, hey, those are doing well overnight. So and that gives me a lot of confidence to stay dissections alone nowadays, especially when the pre-dial, like in the last case, cannot work perfectly because it's a huge of calcium.
Okay, unfortunately, we're running short of time. Matthias, you want to make a comment?
Yeah, so the only comment I would like to make is that, I like DS and DCBs as well. So I think Bruno's comment is very good about that. The time is actually maturing for having large randomized studies, exploring these different strategies and knowing the limits of them, because we are seeing that DCBs perform very well, but at the same time, low-frequency events are really hard to track outside randomized clinical trials. So we need large studies with long-term follow-up as well to see how we can confidently continue to expand this practice, because we need the data to support the use as well. So I think that the fact that with the European Bifurcation Club, their DCB trial is something that's really pivotal, but we need more trials than that, actually.
Well, I'm really sorry to close this session, because I think 45 minutes, it's a little bit too short to go through this very fascinating issue of the dissections. I can anticipate. I mean, we have made a dedicated webinar with Bruno and other colleagues that you can review in PCR online. It's exclusively dedicated to dissection, so probably you will like it. And to end up, to wrap up the session, I mean, we know that in some lesions, DS are not optimal. Drug-coating balloons may add, but we still need evidence to say that. Of course, the use in bifurcations has been long awaited, and according to the results that Matthias has shown in part, I mean, there is hope on that. I can add that this instruction for use has been added in the Prevail device from Medtronic, so now you can use it without feeling guilty, because they used to say, don't do that. Now you can do that with this device. And of course, stents are needed when the vessel is occluded. This is my indication to treat the dissection, which is an occluded dissection. Once you put a stent, the vessel will never grow. It might only get smaller. When, as David said in the beginning, you will leave an awful result immediately, but it will very likely look much better at the long term. So one advice is, if you want to get confidence with this technology, try to bring back some of these patients and control them after 6 months or 1 year, and we will reinforce your beliefs on this technique. Thank you to Medtronic for this opportunity, the panelists, the speakers, and all of you that were able to fill this room. It's very nice to see PCR full of people again this year. Thank you.